Okay, so we will move right along and talk about the immunotherapy and targeted agents in treatment of our disease. And really, the topic of precision medicine and where are we with precision oncology for treatment of gastric adenocarcinoma. These are my disclosures, and what I really want to just take a moment to highlight the importance of advocacy. And again, you've heard this over and over again, but as a first time, I'm a researcher that has been, can give you first-hand experience with applying to these grants, both to the NIH, NCI, and the Department of Defense. And so for the first time, we were able to convince the Department of Defense that gastric cancer is actually a very relevant area to fund for research. There's, the incidence of gastric tumors are increased and on the rise, particularly in young folks and veterans. And because while the service men and women are abroad, they get increased exposure to H. pylori infections, which then can cause gastric cancer. But it is because of Debbie's dream that we were able to get the ear of the government to help fund this research. So I was actually awarded two Department of Defense grants. One was to study BRCA and platinum sensitivity in gastric tumors, and the other was, of course, to study HER2-positive gastric cancer. So the purpose of today's talk is really to review the molecular biomarkers and the treatments in stomach cancer, and also discuss the future directions, particularly the immunotherapy trials that have recently been completed. As you heard at length this morning, 5-FU and platinum is the most important cornerstone of treatment in majority of our patients. And all patients with metastatic disease receive it at some point in their sort of tenure as a patient. But addition of taxane, docetaxel may be beneficial in these select patients. We tend to avoid epirubicin as it has minimal benefit with increased toxicity. And once the disease is deemed chemotherapy refractory, so progression on multiple lines of therapy, the patients have very limited treatment options. So where are we in precision oncology? Human epidermal receptor 2, or HER2, is certainly a validated and the first biologic target that has been validated in gastric cancer. And we enrich patients for this therapy using biomarkers. So a biomarker is how do you identify a subset of patients that will be most likely to benefit, as opposed to giving it to everyone, the drug. And so IHC, HER2, and immunohistochemistry looking at the protein or gene amplification is the way to select these patients. Vascular growth factor, or VEGFR2, is an important target. However, for those patients at this point, the benefit is modest, and we are unable to select by biomarker which patients are the most likely to benefit. Area of research that I'm particularly interested in is this concept of DNA repair, DNA homologous repair, the ataxia-telangiectasia mutated gene, BRCA. These are all pathways that fall under that area. In the interest of time, we won't cover this, but it's certainly, you'll hear more about this in the next few years in the gastric cancer world. Claudin 18.2 translocations are very important. They've been demonstrated to occur more commonly in this genomically stable subtype, and there's been interesting phase 2 data. And certainly the majority of the second part of my talk will be focused on checkpoint inhibitors, or the way to unleash your immune system to help attack the cancer. And although there's some interesting data for MET inhibition and EGFR inhibition, majority of the data, really does not demonstrate benefit in unselected patients, and so we won't cover it in today's talk. Well, you saw the different renditions of this data with the summary of the Cancer Genome Atlas. So the NCI had the effort to characterize and to create an atlas, what the doctors can refer to for their questions, similar to Atlas of Anatomy, that Dr. Netter did many years ago. So what we know about gastric cancer, and historically the esophageal tumors have been really, in studies, studied separately, and at times the squamous histology was lumped with adenohistology. And what this paper that is going to be coming out in Nature, next month or so, has shown that esophageal tumors that are adenocarcinomas are actually molecularly very similar to the gastroesophageal junction tumors, and they're completely distinct from the squamous histology. And so within GE junction, gastroesophageal junction, and esophageal tumors, we do see similar abnormalities that we see in the proximal or, gastric cardia. And again, for the purposes of a clinical trial, particularly in metastatic clinical trial, it's important not to exclude esophageal cancer, adenocarcinoma patients from GE junction or stomach cancer trials, because those are biologically very similar tumors and are driven generally by amplifications in the receptor tyrosine kinases. Those were the EGFR, HER2 amplified tumors. And probably in our Western world, gastric cancer comprises 2/3 or 60% almost 2/3 of our tumors. So those are, when you're thinking about what trials should we do, or what, cancers should we target, in the Western world, it's mostly the chromosomally unstable or the RTK-driven tumors, receptor tyrosine kinase tumors. The other subset that is very challenging is this genomically stable tumors, where you look and there's just not that many alterations. But in those, generally, cell adhesion molecules such as claudin are the drivers, and also ROA mutations. Those are the ones in that picture shown in green. I apologize, I don't have a pointer. And the MSI, the microsatellite unstable, and the EBV Epstein-Barr virus tumors, although are rare, are very interesting and provocative tumors, because in the majority of them, the immunotherapy would probably be the way to go in terms of potentially even eradicating the tumors altogether. Well, the TCGA sits in an ivory tower of having perfect tumor samples that were never treated with chemotherapy or radiation. Early stage tumors a lot of times fall into that category, because in our clinic, as you've seen, majority of patients receive chemotherapy if they've had locally advanced, even non-metastatic disease. And so how does the TCGA data, how is it applicable to our real life experience? Well, so MSKCC has really spearheaded this effort of precision oncology, and through both philanthropic and peer-reviewed funding, we've established the so-called MSKCC Impact, and it's a way to, in a research setting, to try to understand the biology of different diseases, particularly rare diseases like gastric cancer. We have the luxury, and again, this is highly unusual, but all I do all day is see gastric adenocarcinoma. My practice is full of these patients. In my clinic, it's an epidemic. So for me to be able to study a subset of a disease that's rare in the US, and then be able to identify subsets that are even further, or rarer, if that's a word, is a unique experience. And within our group, we have 3 oncologists, so myself, David, and Jeff Koo, that focus only on this disease. So it really gives us an opportunity to identify subsets that are rare and perhaps are, not as commonly seen out there in the real world, but that's how you sort of form the hypotheses. So when we see the patient, so every single metastatic gastric cancer patient that comes through my clinic and are staying for therapy at MSKCC get approached about to give written informed consent, and they watch a video where a sample that is already available on them, we don't do generally extra biopsies or procedures that are unnecessary, is taken, and then they also provide a normal sample with blood, so for DNA comparison. So this way we can compare their germline, so what their mothers and their fathers gave them, and their somatic alterations, what you see in the tumor, what drives their cancer, and analyze their tumor. And then every single case is really reviewed closely with a molecular pathologist, an expert in the disease. So for gastric cancer, that's me at MSKCC, and the bioinformatics to try to understand what's important about this tumor. Because, for example, P53, as David said, is a tumor suppressor. So it's not really going to be able to, help us identify the target. But c-Met amplifications or having EGFR HER2 co-amplification and so on may be important. And so this is determined and then actually reported back in the medical record and becomes part of patient's medical record because the New York State had approved this panel. And now it contains close to 500 genes that are important in the driving the disease. And so this is probably the largest cohort, and it continues to grow. Even this is the presentation I did at the European Society of Medical Oncology just a few weeks ago, and already we have more samples. But it's samples from 319 patients, all of whom had metastatic disease. And as you can see here, these patients were followed through the natural course of their cancer, and in a good proportion of them, we were able to get multiple samples to try to understand how their disease changes. And the purposes of this was not to match, as Lakshmi was saying, there's a match protocol and NCI effort to try to match patients to clinical trials. This was more to understand what the natural history and what will happen to the patients and how we can, track their tumor and determine which trials we need to open sort of in a rational way and understand their disease. There was a pretty equal, distribution between gastric and GE junction and stomach tumors, and majority of the patients presented with stage 4 disease, as you can see here, 68%, and a third of the patients presented with localized disease, and subsequently, when they recurred, we included them in this cohort. HER2 has been always an interest and research focus of mine, so there's a higher propensity or a higher percentage of HER2 positive tumors in this cohort, again, based on the referral pattern for clinical trials. What do we know about HER2? Well, monoclonal antibody, Herceptin, or trastuzumab, has been on the market, and after the initial study came out, it was already, NCCN and FDA guidelines approved in 2009. We know that trastuzumab really raised the bar for overall survival, and then strongly HER2-positive tumors, the overall survival for first-line study of 16 months at the time was unprecedented. So it really, changed the game, and for the first time highlighted the importance of targeted agents in our disease. Since then, however, we haven't been as successful in demonstrating that other agents that are FDA approved in breast cancer are efficacious. Pertuzumab, which is another monoclonal antibody that binds to the HER2 in at a different location, is under study now, and hopefully that data will be published soon, and we're very eagerly awaiting this. The TDM1 drug, which is a trastuzumab, which binds to another DNA cross-linking agent, failed to improve outcome over second-line Taxol. And you hear a lot saying that, well, that means HER2 is not an important target in gastric cancer in second line, et cetera, et cetera. But the way that I would interpret this data is that TDM1 did not fail, it just did not do better than Taxol. And what you really were hoping to do was quite ambitious. I mean, DM1 is just another DNA cross-linking agent, and then you're presenting patients with that were already refractory to another DNA cross-linker, which is platinum-based therapy, and expecting them to respond. This was, not a surprising result. Lapatinib, which is a small molecule inhibitor that targets EGFR and HER2, overall were negative trials, but again, a subset of patients with strongly HER2-positive disease have been shown to benefit. Well, so as some of you that are focused in HER2 may know, HER2 is a transmembrane receptor, so it crosses the cancer cell, and so part of it is outside and part of it is inside, and is a member of 4 receptor superfamily, EGFR, HER2, and HER3, and HER4. Once the HER2 gets activated, it helps bind other receptors in the family and then becomes activated with downstream activation of other important growth factors such as AKT, MAP kinase, and so on. A lot is known about HER2 resistance in breast cancer, but not a lot is known about it in gastric cancer, and it hasn't really been a comprehensive published result in patients. In cell lines and tumor models, there have been some reports from groups in Boston and so on. But in breast cancer, what we know, activation of parallel pathways such as MET or IGF-1R, or downstream pathways, AKT, and that's what you see in the pictures, or mTOR on the right, has been implicated in gastric cancer. So in our cohort of 105 patients, we looked at patients with trastuzumab refractory disease and also patients on whom we've had matched pre- and post-trastuzumab biopsies. And it's the matched cohort was 33 patients, which is our largest cohort, but then the unmatched cohort where we had 44 patients with trastuzumab refractory disease. And really what we see is that the tumor changes. And think about it, these are patients who progressed on standard therapy and then were agreeable to have a research biopsy. So most of them were enrolled in a clinical trial where the biopsy was mandatory. But I can tell you, I have not had a patient. And I do a lot of speaking. I do talks at various institutions, and some of the clinicians or pharma representatives raise the concern. Well, the patients may not want to do a biopsy, et cetera. If you rationally explain to a patient why a biopsy is needed and it's safe and relatively, quickly done, I have not had a patient decline because they really understand that, you can't go into a battle with an outdated map. You really have to understand what you're targeting and why you're targeting it before you can move forward. And so for the patients who came to see me for a HER2-positive clinical trial, I told them, I said, look, I don't even know that your disease is still HER2 positive. And in our experience, patients, their tumors lose HER2 expression. And so if I'm going to, and I love putting patients on trials, thank you for coming to a trial, but I don't want to offer the wrong trial to you. So before we decide what trial you should go on, you really need to understand what we're dealing with. And if you look at these second-line studies for lapatinib, for example, a lot of times the tumor was tested, it was outdated from 5-6 years before, and again, the tumor really changes. And what we did see is that loss of HER2 occurred in approximately 20% of gastric tumors. So it's basically either a cell that is HER2 positive was completely killed, and then the only clone that was HER2 negative was growing, or they literally just shed the HER2 protein and the receptor. We don't know that, and that's under the investigation. But also activation or upregulation of other parallel pathways such as EGFR, MET, IGF-1R, and so on occurs. As you can see here in percentages, the percentages on the right is the after. So 7% versus 12%, 100% with HER2 positive, only 78% are HER2 positive after. KRAS, which has not been a big focus in the resistant pathways in gastric cancer up to date, has been shown, in this cohort to be increasing if the tumor becomes resistant. And this is, again, a so-called oncoprint where, on the left you see 88 patients who received, who were trastuzumab naive and their tumors were sequenced, and then 49 patients who were trastuzumab refractory. And as you can see here, upregulation of SMAD4, mTOR, and things that you wouldn't, again, there was an mTOR rapamycin trial, and there's always a tail on the curve, but no one really looks as to why some, even if it's only 5 or 6 patients or even 15 patients, for that patient, it made a big difference. They did better with a targeted agent. But what we really done historically is that a large phase 3 study is negative. We're going to close the door on a drug and not look at it again. So mechanisms of resistance in HER2 involve loss of HER2, frequent secondary alterations in RTK, RAS, PI3 kinase pathways, And I really, highlight the importance of repeat biopsies to accurately determine appropriate use of second-line HER2-directed therapies. This heterogeneity of HER2 expression, we say heterogeneous means that some of it is HER2 positive, some of it is not, but also heterogeneity or differences in HER2 between the primary tumor, because someone brought up a good question last time. If the primary tumor is responding, does it mean that the metastasis will respond? And usually the answer is yes, but with HER2, it has been trickier and not always as straightforward, particularly because so far the drug dosing in our disease really goes by historic or phase 1 data. And with these monoclonal antibodies, such as ramucirumab or trastuzumab, you can push the dose quite high, and we don't know if the same dose is appropriate for all patients. So I was, interested in exploring this concept of functional imaging. And the idea is you certainly can't biopsy every single site of disease, in a patient who has a liver metastasis, a lymph node metastasis, and so on. And it would be nice to be able to get a general, look, non-invasive look as to what is the HER2 status of different sites of disease. And this is a picture of a mouse that we gave, and my daughters always get very stressed when I show them, that we give mice cancer. But it's basically a model of HER2-positive gastric cancer, and this is the NCI N87 model. But we've also been able to establish patient-derived xenografts from HER2-positive tumors. And what we see is that zirconium trastuzumab PET scans, or it's basically Herceptin that's radio-labeled with a radioisotope called zirconium-89, shows HER2-positive gastric cancer. And it's specific to HER2-positive gastric cancer. The general radio tracers that you all get, in clinic is fluoridated glucose. It's sugar that's radio-labeled with radioisotope. And basically, it lights up in your rapidly dividing cell, which cancer generally is, but it's certainly not specific for HER2 cancer. As we've learned, that inflammatory changes and so on can also have false positives. So the insert on the right shows to you the control, which is untreated tumor. And then what happens when we treat HER2-positive gastric cancer model with a small inhibitor of EGFR and HER2 called afatinib. And as you can see here in black, the bar shows that the zirconium trastuzumab PET scan uptake goes down quicker than the FDG and is more specific. So when the tumor continues to shrink, the zirconium PET, again, shows it in a more reliable manner. And this was, a preclinical model. It certainly was just hypothesis generating. But I was interested in taking this to patients, and we're actually able to make zirconium trastuzumab PET scan, the radioisotope at MSKCC. Again, we have, all the resources and the radiochemists to do it. It's not a cheap endeavor, and this is part of the DoD funding to do this, but we've imaged already 25 patients. And this is one of my patients who came to see me after progression on all standard therapy with trastuzumab-based therapy. And he was having quite a bit of dysphagia or swallowing difficulty related to that lymph node conglomerate that you see indicated on the left with an arrow. And this lymph node was pushing on his esophagus. He wasn't able to swallow well. For what you see down below is the GE junction tumor, which is shown with another arrow, and then the liver metastasis. But you can see already that there is this degree of unevenness or heterogeneity between the staining, between the uptake. And this patient qualified, we biopsied his tumor. He was HER2 positive, again, showing that the zirconium PET scan correlated with the presence of HER2 positivity. We did have 3 patients on the study out of the 25 that did not show HER2 uptake on the zirconium PET scan, and at the time of biopsy, all of those tumors were negative or very weakly HER2 expressing, so they were, not strongly expressors. So this patient, when he started taking afatinib, just after 3 weeks of treatment, you see the PET scan on the right. So this was before even we did a CAT scan. And the other reason to do these PETs or try to develop them is to try to predict who are the patients who are not going to benefit. And so that you don't, in clinical trials, generally you wait 2 to 3 months to scan someone, and in that time, their disease could progress. The idea is to try to identify a biomarker so that you don't subject patients to unnecessary therapy, and hopefully when there is better treatments, you can just move on to the next best thing. And so in this patient, his dysphagia or swallowing problem has improved, and he was doing well, but this PET scan worried me. And the reason why is because although the posterior lymph nodes completely went away, some sites of his cancer remained strongly positive or hot, as you can see here in the primary tumor. Even though that tumor was shrinking and the liver metastases was shrinking, I could tell that we were not inhibiting it sufficiently because it stayed hot on the PET scan. And unfortunately, when his disease did progress, and he stayed on this treatment for 6 months, again, with just a pill, and so it really gave him quality of life benefit, but when he did fail, he failed in the primary tumor and the liver metastasis. And then that other lymph node, which was biopsy-proven disease, had gone away. So again, this highlights that we need to be able to identify mechanisms of resistance and continue to assess our tumor with biopsies and imaging to understand why patients who don't respond, how can we target them better. I will just give you a word about VEGF inhibitors and that, again, in second-line setting right now, after patients progress on Herceptin and chemotherapy, there's no standard HER2-directed agents that are available. And VEGFR2 inhibitor, ramucirumab, which is, you saw the data earlier in the day from the REGARD and the Rainbow study, has really shown that VEGF inhibitors are important in the treatment of gastric cancer. There are other inhibitors that are on the market that, as you can see here again, VEGF is a transmembrane receptor that ramucirumab, as shown in white, targets the receptor at the ligand binding or outside. There was another drug, bevacizumab or Avastin, that came very close to being positive, but it was not a positive study. And we can, talk about patient selection and so on at a different symposium. But, bevacizumab binds the actual ligand. Ligand is what activates the receptor, and then the receptor is what, is actually on the membrane of the cancer cell. And then, but there is a drug called apatinib that's, in that blue square, turquoise square, which binds to the receptor inside the cell and has also shown very similar activity. And what we know mostly in Chinese patients, this was a Chinese study, and then there is another drug called regorafenib, which is also small molecule inhibitor, that has shown benefit, and this is a large Australian study that they're doing a follow-up study with. What I'm trying to, and I'm not trying to confuse you with this, but what I'm trying to show you that study after study after study has already shown this, paints the picture that VEGFR2 inhibitors are important in gastric cancer. And I think the data is real. I think it's important, but unfortunately, in majority of the patients, the benefit is very modest. Modest benefit in second and third line patients. We certainly are not curing patients with these drugs, but they are improving and they have real, robust overall survival benefit compared to chemotherapy. They also help drugs work better. So in the future, VEGFR2 inhibitors are likely going to be to help, sort of deliver drugs to the tumors. Overall response rate with Taxol in second line setting is quite remarkable, 28% compared to the published literature. But as a single agent, majority of the patients have at best disease stabilization, where the cancer just does not grow. So in patients with slow growing, or we call indolent tumors, or small volume of metastatic disease, it may be a way to get them off chemotherapy and help them just stabilize their cancers and get them through some of the other toxicities that have experienced with previous drugs. Unfortunately, there's no clear biomarker, and so if we could find a biomarker, perhaps we could find a handful of patients that could, really benefit, but we haven't. Some studies suggest perhaps if we get to a higher level, in patients who get higher levels of the blood and of the drug in their blood is important, but this is under development. But you saw this. I mean, even if it's modest benefit, and I'm trying to stress it, that some patients do benefit dramatically, it's much better tolerated than chemo, and it's not any worse, at least at the disease stabilization and survival benefit. So certainly a game changer in some ways for certain people. So to finish up and to sort of present some of the data that's probably on everyone's mind with the the publicity in the New York Times articles about immune checkpoint inhibitors. So the checkpoints are the checks and balances of your body. If your immune system goes unchecked, this is how people develop rheumatoid arthritis, lupus, terrible liver inflammation, and so on. So it's important to have a check to your immune system. However, your immune system failed you. Patients who develop gastric cancer, there's this one cancer cell that started to grow or divide inappropriately. In some patients, your immune system could suppress it, but in majority of patients of gastric cancer, this immune surveillance failed them. And so the idea behind checkpoint blockade is to try to get your immune system in gear and get it to attack the cancer. Because in some ways, it has been, the immune system has been exposed already to everything that may have caused your cancer. So, gastric cancer is so complex and difficult to study and target because it really challenges this one target, one biologic, inhibitor concept. So in, EGFR mutant breast cancer and EGFR mutant lung cancer, rather, one drug, erlotinib or Tarceva, can really cure 80% of patients. But in gastric cancer, there's a number of different alterations that occur in the tumor altogether, most likely because the stomach and the epithelium of the stomach, the lining of the stomach, is exposed to a lot of different insults. But guess what? Your immune system has been also exposed to these insults, and that's why the mutational burden and what David has showed you, that graph with the different levels of mutations, on that spectrum, gastric cancer is number 5. And the 1 through 4 are the diseases where immune checkpoint inhibitors have already been approved. So we're really, a disease of great interest to immuno-oncologists. Because it has a potential of really to be immunogenic disease, but not in all patients. So how do what are these immune checkpoint inhibitors? So you can basically take the brakes off the immune system, which is sort of anti-CTLA-4 blockade, or you can also remove sort of the clocking device, the invisibility cloak that the cancer has been wearing, saying to your body that I'm okay, I'm safe, don't kill me. So that's the sort of PD-1 and PD-L1 inhibitors, the programmed death receptor inhibitors. And both of those agents, or class of agents, have been extensively studied in phase 2 and 3 studies. And, this field is so new that there is probably 800 different studies going on across different solid tumors. And in gastric cancer, the only one has been really actually published in the manuscript format, and the rest are still, in abstract and sort of work in progress. But what we already know is that single agent anti-CTLA-4, you remember that's the brake, alone, so drugs like tremelimumab or ipilimumab, those are the CTLA-4 inhibitors, have no single agent activity. So, those have been studied by themselves and probably don't do much by themselves. And interestingly, they're the ones also that cause a lot of toxicity as well. But single-agent anti-PD-1 inhibitors, those are the ones that that remove the invisibility cloak. Drugs like Opdivo, nivolumab, or pertuzumab, or pembrolizumab rather, or Keytruda, have single-agent activity, even by themselves in subset of patients. And I've seen that happen in my patients where they change their lives, the patient's lives, they do have dramatic responses. It's very rare. In unselected patients, it's probably 10 to 14% overall response rate. But unlike chemotherapy, where the chemotherapy works for 3 or 4 months in refractory disease and stops working, some of these responses are quite durable and can last a year to 2 years. What are the biomarkers? I keep saying biomarkers. So how do we select patients for these inhibitors? And although immunohistochemistry and looking at the target called PD-L1 may be a relatively helpful biomarker, it is not. It's not the only biomarker, and I would urge the pharmaceutical companies and the patients and sort of the designers of the next generation of these trials not to exclude PD-L1 negative tumors from these trials, because we do see responses in PD-L1 negative tumors to immunotherapy, and I'll show you some of this data. Gene expression profiles, MSI, and EBV status is probably sort of the wave of the future to identify patients who are the most likely to benefit. And in our diseases, combination therapy. So in fit patients that are feeling well and can stand the risk of increased toxicity, dual PD-1 or PD-L1 inhibitors with CTLA-4, so nivolumab and ipilimumab, or the tremelimumab combinations, have greater responses. So 26% response rate, but comes at a cost of much higher toxicity. Other drugs such as avelumab are on the market, and the future, again, in gastric cancer is likely combination therapies. We talked about VEGF-R2 as being a potential drug delivery system to help improve the cancer, sort of the access of nivolumab or pembrolizumab to the cancer, and also increase immunogenicity of the cancer. So there's a trial with ramucirumab plus pembrolizumab, and we're doing at MSKCC a trial of trastuzumab in HER2-positive disease in combination with pembrolizumab, again, to try to build on what we know about these HER2-positive tumors. So Keynote-12 is the trial that has really, highlighted the importance of PD-L1 inhibition in gastric cancer, and this was 53% response rate. This is a waterfall plot. Each bar is a patient, and their size of the tumor is shrinking with immunotherapy, which is very important. And this is the trial that we recently completed to look at monotherapy with nivolumab versus combination of nivolumab and ipilimumab. And as you can see here, these were 2/3 of the patients progressed on 2 or 3 lines of therapy. So they already had their platinum, the taxanes. Some of them had other trials. And what I want you to focus on is the toxicity. I have patients who come to me, very ill, not able to take care of themselves. They are wheeled in, and they say to me, "Please, doctor, give me immunotherapy," or they come from afar for a clinical trial, thinking that immunotherapy has no toxicity and it's, good for you somehow. But as you can see here, 46% grade 3, 4 toxicities with combination therapy. 50% of patients had significant toxicity where some of them even had to be admitted. So it really is not for everyone, and it, really needs to be, the patients need to be carefully selected. But the reason why I included this slide, and I apologize for confusion, for a busy slide, to show that PD-L1 negative tumors respond as well. So if your oncologist ever tells you, "Oh, well, you have PD-L1 negative tumor, probably not worth pursuing immunotherapy," I would challenge that. And again, combination therapies are probably the best to target those type of tumors. Here you see some responses in PD-L1 negative. And just to finish up with a patient anecdote, because they always make me feel better, this is, examples of the type of responses that we've seen. The patient on the left, had a significant response in their tumor. Again, this is a chemotherapy refractory tumors. And this is my patient on the right with biopsy-proven large lymph node metastasis and other metastatic disease that responded to immunotherapy. only after 2 weeks of single-agent pembrolizumab or nivolumab therapy. And what was interesting about this tumor, this is her profile. As you can see here, numerous mutations, and this is each line is a mutation, and that's the tumors that are probably most likely to benefit. She went on to, she was basically being sent to hospice before she came to us because she exhausted all standard options, radiation, and even had phase 1 trials. She's been on a couple of phase 1s. So what's interesting about her tumor, unfortunately, her response was, lasted only 14 months, which is, made a big difference in her life. But after progression, we biopsied her tumor again, and she developed a resistance mutation that inhibited binding of nivolumab to her cell. And so in her, actually, then we gave her a combination of nivolumab and ipilimumab, and that's her PET scan after. This is the bottom left. And she started to respond once again. So again, it highlights the importance of close follow-up, always sort of, examining where are we going and not going by outdated functioning and, mutational status. And with that, I'll finish and just say that this is a complex disease biology. We identified loss of HER2 as an important, change in the HER2-positive tumors and activation of other receptor tyrosine kinases. We need to biopsy these tumors and look at the loss of heterozygosity in other genes to identify better targets.